Okay, good morning still, yes. Thank you very much for your attendance today. So this is one of three concurrent sessions taking place. So we've got three speakers, Jane, Nicole, and Ian. And each speaker will speak for 15 minutes. And that should give us then 5 minutes for questions directly to that speaker. And then at the end of that, if all things go to well and on to time, we'll have 15 minutes for further questions or comments, especially from you guys, would be very helpful. So it's my pleasure to introduce my colleague, Jane. Jane, you say a little bit about yourself.
Yeah, sure.
Your 15 minutes.
Starts now.
Okay.
Hi everybody, I'm Jane Pepper. I am the trauma lead for the Merseyside Violence Reduction Partnership. You will have heard the PCC talking about how we've trained 4,000 people across Merseyside. We've actually supported around about 4,000, and of that 800 are police officers, a number from education, they're from literally every walk of life. If you haven't signed up for trauma-informed training, it's free to public services, so please do. You will notice on your chair there is an A or a B to keep it top secret. This is an oxytocin here. We're going to talk about oxytocin a little bit and about how we release it. So oxytocin is released when we give birth. It is released in the mother and it's also released in the baby, and the whole purpose behind oxytocin is our love chemical. It's how we bond, it's how we connect. So we're going to do a little bit of that now. Please feel free to move your chairs because we're actually looking at you potentially facing the other person while we do this activity. You can move your chairs back afterwards, that's absolutely fine. But the intention is that if you can actually face a B if you're an A and face an A if you're a B, it's on your chair. So don't tell the other person what you've got.
There you go. I'm an A, so I know what
Anybody not got an A or a B? If you haven't got an A or a B, please do me and yourself an A or a B. Okay. Right, everybody, I am going to ask you please to start telling what it is that's on your sheet, if you're an A. Has anybody not got an A or a B?
We know each other, so should we find
Doesn't
someone else?
matter, that's absolutely fine. Yeah. Have we got anybody available? B? You're a B and don't have an A? You're an A? You're a B as well.
3.
You've got a B?
Take that A.
Yeah. If you read the A, then you two can sit together. Is that okay? Are you all right coming down here? Is that fine? Okay, folks. So I'm going to ask you to start doing that as of now.
And then when we sat down at the meal, we have our
Okay, stop there.
rude. Very rude.
Okay.
Rude.
It is very rude, isn't it? It's really,
Have you noticed?
rude.
That was never 45 seconds.
I know, that was the intention. So, for those people who are A's, who were trying to tell their story, and then all of a sudden, I noticed Nick was on his phone straight away. For those B's, who then turned away or totally, completely switched off from you, it's a horrible feeling, isn't it? It's a really unpleasant feeling. You start to feel like, why are you not talking to me? Why are you not looking at me? What's happened is actually oxytocin is released when we start communicating and when that other person is actually really connecting with us. When we've got about 20 seconds of that interaction, we start to get that lovely feeling of oxytocin, like I'm being listened to, like I'm being really, really kind of engaged in the situation. When that goes and that other person disconnects, we get a horrible sinky feeling. So the purpose behind this hit of oxytocin is really getting you to understand that connection on a deeper level. What I would like you to do now is with your A and your B, we're going to give you a sheet of paper. Hopefully you've got a pen. If you haven't, we've got a whole set of pens here. The wonderful Merseyside Violence Reduction Partnership pens, which are awesome. Can I just and if you could please, you can write on your top secret sheets, that's absolutely fine as well. We're going to ask you to do an activity now with your A's and B's, which hopefully is going to release a really, really nice level of oxytocin.
There we go.
There are some rules to this activity, so you're going to have to listen.
Thanks. Okay.
Has everybody got a piece of paper? You will need a piece of paper each. And you need a partner.
Need any paper? Has everyone got a sheet yet? We've just done an activity with an A or a B, and then now we're about to start a new activity. Hold on my See the pen to be able to write down for this.
Folks, so we're going to need you to get into a situation where you can actually look face to face with the person who is opposite you. That might require you to move your chairs. You can move them back afterwards, that's absolutely fine. But you need to be looking in the other person's face. So you can shift your chairs around so you're looking at each other.
Do you want us to do anything? Everyone look.
So you're actually watching it. So for this activity there are some rules. Folks, for this activity there are some rules. And those rules are really, really clear. Number one, you cannot take your pen off the paper. Number two, you must continue to look at the person opposite you. You've got to give them eye contact. You have to look them in the face. Number three, you're not allowed to look at the paper. Number four, and this is the last one, and then I'll set you off going. You are going to draw the other person's face on the page. Off you Cheating.
Right, well, next step. I
I mean, that definitely does all
Drawing.
What do you about the school?
not going to get.
Can we do it
Okay, folks, if you have completed the drawing, could you please hand that? Could you sign your name as well? Could you hand that to the other person?
Potato head. It's cool. The potato head.
Tomorrow project.
Okay. Folks, if I can just get your attention, please. Right. What on earth have we just all done? What have we heard?
The masterpiece.
Lots of laughter. Absolutely. It's really hard, isn't it? It's really difficult to actually do that eye contact for any length of time. We start to feel really, really uncomfortable. But actually, how do we support ourselves when we feel that uncomfortable? We start to giggle. The more we can actually get that kind of connection in people and the more giggling that we're going to get, the better we're going to feel. When we giggle, actually, we're filled with all of the nice chemicals that help us to bond and connect. So the whole purpose behind this activity is really to get you to understand that we all need oxytocin. We need oxytocin in our daily lives. We need oxytocin to connect with each other. If you've never even met the person that you've been doing this activity with, you've now got a connection that you didn't have before. And they've got your signature. Yeah.
What a piece of art.
Absolutely.
Put it on his wall. And
I will tell you, our training that we deliver, it isn't just about giggling, but it's very much part and parcel of coming along to this session. Although we talk about trauma, although we talk about adverse childhood experiences, although we talk about attachment difficulties, it's all done with playfulness. Because playfulness, we learn so much faster, we build that oxytocin, and actually people feel way more comfortable. When they walk through the door, they know that we're going to talk about trauma, adverse childhood experiences, physiological responses to all of those things. So we've got to settle them in. We've got to make them feel comfortable. If you haven't signed yourself up on the training, please go on the MVRP website. If you work in public services or the third sector, you are more than welcome to come. Completely for free at the moment. Get yourself on it. It's 4 sessions and we take you on a journey. We take you on a really, really comfortable journey. We do trigger people on occasions, it's not intentional, but we also have all of that supportive network in there to support you if we do. Okay? We know a lot of people who've fed back have actually gone through therapy at the same time as coming on the training and they've found it really, really helpful. They've even decided, I'm not in the right place to come and do session 3, so I'm going to come on session 3 in a month's time or 2 months' time. And we've had that as well.
Can I just ask, is the training over 1 day, 2 days?
So it's 2 hours training on any given day, and it's 4 separate sessions of 2 hours training. And the reason behind that is because what we know is, first of all, if we delivered it all in 1 day, we'd be exhausted. We'd be absolutely physically exhausted because it's intense. It's 2 hours of intense. You're learning all about neuroscience, you're learning all about attachment, you're learning all about child development, you're doing it through play. But as well as that, we know that if we want to embed that long-term understanding of trauma, attachment and ACEs, actually we need you to go home and sleep. We need you to embed it in your long-term memory. So the more you can come back, the more you're developing connection as well. We get to the end of the 4 weeks and all the delegates go, what the hell do I do next week? Sorry, we've got to go off and teach a whole load of other people. Once you've completed the 4 sessions, you're then eligible to come on the Trauma Informed Conference. And the Trauma Informed Conference is about embedding trauma-informed practice within organisations. Again, we take you on a journey of how to measure yourself to see how trauma-informed you are, but then also how to implement all of the things for trauma-informed practice.
Very good, very thought-provoking.
Thank you very much. Always good to have a delegate.
Have another couple of minutes.
Another couple of minutes. Any more questions?
It's in person then, or
So we do in person. We're actually trialling a hybrid model at the moment with the police. That's how we're managing to get through so many police officers. Session 1 and session 2 on an e-learning package, and then they come and do session 3 and session 4 at a later date in person. We're also trialling that with Sefton mental health team. They couldn't, because of their timetables, actually manage all of the 4 sessions. Most people want us to tick a box and go, yay, we're all trauma informed. No, it doesn't work that way, I'm afraid, especially when you're actually embedding change. So we've just got to do it a bit differently. But we're looking at different versions for different organisations and delegates.
Can I ask, when are the conferences?
So 28th of February is our next one, but unfortunately all of the places went in a day. We have another one coming up on the 28th of March, but you need to have done the 4 sessions beforehand, because otherwise you come along and go, sorry, I'm not quite sure what's going on. So
I did them a while ago.
you can come on the 28th. The email will be coming out at the end of January. And then we'll have more going. We're just waiting for the investment, really.
I'm just going to introduce myself because I said hi. I'm just stood here smiling alongside Jane. I'm Abby. I saw Jane's training when I was a senior leader in a school in Liverpool, been teaching 18 years and followed her out and basically got in a suitcase. I now do it full time. This is my job, and we're delivering separately so we can hit more places. So we're based all over. We'll go to wherever is needed. So we're in Southport one day, Wirral one day, St Helens one day, and we move around separately to ensure that we're getting as many people trained as possible in the time that we've got.
What are the topics of the 4 sessions?
Ooh, we can send you a flyer on all of that. But
It's the latest research on the neuroscience of trauma and adverse childhood experiences and how that impacts every part of life. So we know that the first 1,001 days are essential, and then every day after that, all the experiences you have leading up to a traumatic event and the social network you're part of, everything leading up to that will explain your trauma response and how trauma lives in you or your experiences as an adult later on.
Could ask.
Sorry, I don't know if
Sure,
someone
one more. Okay, one more.
register for
Yeah, how'd you go on
How'd you get onto it?
go on the MVRP website, have a look for the trauma-informed training, and then just book yourself on. And
Except you're full in St Helens.
We are.
we are. But we've got another St Helens
Spaces.
course coming.
Oh, have a
Yeah, in
There's
March.
spaces in the Wallasey one, Egremont Primary School. Anybody's welcome to come into the school. There's a morning session and afternoon starting on the first Monday in February.
We've got
That's-
Quaker House as well. So we've got full sessions at Quaker House in the morning and afternoon in April.
Just behind Primark in town.
March, April.
Okay. Thank you very much. Show your appreciation. Thank you. Thank you very much for keeping the time.
welcome.
Super. Our next presenter is Ian. Ian, you introduce yourself, but I've known Ian for an awful long time. And I was witness to one of the new videos that you've published now around kind of adversity, risk of suicide amongst former armed forces, which was absolutely amazing. So delighted
We'll
that
be
you're
talking about that today.
not today, but delighted that you are speaking to us today. And I'll let you to introduce yourself. And again, you've got 15 minutes to do
Thanks,
that.
Andrew.
Thank you very much.
The slides.
It's on there. It's on the clicker.
Yeah, just briefly, Ian Whiteside. I work for an agency called Beacon Counselling Trust. My role there essentially is early intervention and education. We're a treatment provider, which I'll kind of elaborate on as we go. Quick question for the room. Who's had gambling training previously? Not that many. And the ones that are putting the hand up, the ones I know. So you have to, okay. So one of the things from today, really, we want to encourage more people to receive training. Beacon is based in Anfield. I'm not going to go through all the various programs that we deliver. We're a mild to moderate mental health service provider. But what we're kind of really known for across the Northwest as part of what's called the National Gambling Support Network is that we're a commission provider to support the entire Northwest for everything to do with gambling. So that includes treatment and support. And we're not just talking about gamblers, we're talking about people who are impacted by gambling and affected with their sort of family members who often and I put this statement up back in 2021 that then Health England kind of had a focus on gambling for the first time. And this statement from Rosanna said, you know, the evidence is clear that gambling-related harms is a public health issue. And it's probably one of the big kind of crusades we're on really, trying to get parity of issue, because often people don't always consider gambling. You know, I'm from a youth work background, and if I look at early help in particular, it's not mentioned anywhere. That's got to change. So, as a public health concern and working to support families, children in particular, think about ACEs. The first time I've ever seen gambling linked as an ACE in that report, which is fantastic. So it's a public health issue, and it needs support from everybody there. And when we talk about gambling and gambling-related harm, we have to define what we actually mean. So the act of gambling is just gambling. Doesn't mean to say you've got any issues with it. Gambling, as that statement says, means that you're risking money usually. It's not always money with young people. It could be their clothes, their phones, food. You see that? But it's not guaranteed. It's based on chance. People think about luck. I don't believe in luck. When we think about gambling, it's simply chance. You either win or you don't. Usually you don't. But when we think about gambling-related harm, it's those adverse impacts to that person or the wider family member and society as well. So we think about the cost of public purse, certainly in Merseyside, is about £28 million. We know that. We look at all the different bodies across the Merseyside area, when we're looking at criminal justice, health benefits, the cost was £28 million. So there is a wider impact when we think about gambling. I'm not going to go through all this, but just to say, gambling works along a continuum of risk and harm. So you'll be somewhere. It doesn't mean to say you start there and go to the end. Some people do. And you can, for some people, reverse some of it. Once you get to the red area, which is classed as gambling disorder, if you've been kind of diagnosed with that, often some people with lived experience say, I can't go backwards, I can't go back to gambling socially. That's not for me. Some people have. There's no rule to this. But generally, people find themselves somewhere. I always remind people, it's okay not to gamble. Choose not to gamble for various reasons. So it's just a reflection, really, that gambling acts along a continuum. Lots of risk factors. I'm not going to go through them all. Some of the key ones, people say, why is being more at risk? And particularly an early win. When someone wins from a bet, and it's a significant amount, that is a core indicator that they might, in the brain, start to think, distorted perception, I could do that again. And wouldn't that be great? But that's not the reality of it. Things like significant life events. You could have had a redundancy payout and trying to stretch you. I've seen that. There could be intergenerational transmission. Your parents gamble. It's normalised. You do it. The Grand National comes up every April. Children will be helped by their parents to put bets on. And it's a criminal offence, but no one has ever been prosecuted for it. It's that kind of thing. These are risk factors. Again, I'm not going to go through all this. Probably some of the key ones is that 50% of people gamble on a regular basis. We look at across the whole of the year, 60% of us gamble throughout the year. We know that there's about 6.8 million people suffering some form of harm, either theirs or impacted by somebody else's gamble. These numbers are not something that everyone's very familiar with, but something that people, through our training and more awareness, encourage them to think about what they do and what they do in their services to address some of this. And even where we think about young people, some reports are showing that 50% of young people in school have said, I have gambled this year, even though legally they're not able to. Big risk factors for us in terms of our client group and safeguarding is that you're 15 times more at risk of suicide than the general population if you're suffering gambling-related harms. And this is the thing that we see a lot in our practice. I'd say about 60% of our client group have said they've contemplated suicide because you don't know any way to get away from it. That's an awful situation to be in, but it's something that's very common with this group. Our treatment numbers are going down, not up. We want to change that. Only 3% of people are coming forward for support, and they usually only come in at crisis point when everything's really gone, it's kind of quite seriously wrong. We want to change that, so early intervention being important. I've highlighted a couple of things because there was mention of ACEs there. In terms of young people, 1 in 80 children experience tensions at home, witnessing arguments, and they know it's about gambling. In fact, 1 in 80 children in the Merseyside area, we did a kind of a little maths on this, about 4,000 children in Merseyside alone can't sleep at night because they're worried about their parents gambling. It's an awful, again, situation to be in. And this whole idea, again, of domestic abuse, that was mentioned in some of the slides from the early introduction this morning. I'm really pleased to see that report, and I will use some of that going forward. This slide just represents what Merseyside looks like in terms of risk and harm. So I'll draw your attention to the low levels of gambling and gambling disorder. We're below the national average. But if you look in the middle, this is moderate risk gambling. This is where gambling is having episodes where it is risky and harmful. And we're above the national average. Now our worry is if we don't do some more early intervention, they're going to creep into this gambling disorder kind of category. So we need to be doing some more work, training, early intervention, screening and identification. We've developed what we call our 10-point plan to mobilise local systems. Essentially what it is, a bit of a blueprint looking at these 10 issues in no particular order about what agencies and organisations can do to start to think about how can they maybe look at gambling and improve outcomes for people within their own services. The big one, awareness, get some training. We have a workplace charter that looks at if you haven't got a policy, many agencies haven't, where they'll have a drug and alcohol policy or a mental health one. Very rarely they've got a gambling policy. We will support individuals and agencies to develop that. I'm racing through because there's 2 key slides I want to do and Sue's going to come and help me in one of them. Just to say really, we do have some targeted interventions. Andrew mentioned one earlier. Our latest one is looking at the armed forces community who are 10 times at greater risk of gambling related harms than the general population. And some of that is because of their culture and their environment, using gambling to de-stress, boredom, being isolated at times. This is something that they're a high risk group, as are the others in there. But these are just some of our kinds of key target programs. And if you're interested in this, come and speak to me later. Workplace Charter is that kind of initiative that we've developed. As I say, it's about getting organisations to think about what policies have they got, have they received training. One of our training offers in this particular scheme is that you can do a full day programme and receive a level 2 award in gambling related harms if you go through this process. So it's the only one of its kind in the UK. It's accredited by the Royal Society of Public Health. So if you go through this process, you can put your staff through this training programme and you get an accredited award for it. Thinking about criminal justice, because these are some of the things I want to kind of make a focus on. 2 police authorities in the UK have signed the charter. If you're in the police, you can be dismissed. You're a threat, you're a risk, you will know this. You're open to corruption. But within the police, and particularly Durham and Cheshire, what they did is they built in a gambling harms section in their unmanageable debt policy, so that officers could come forward with confidence saying, I'm struggling with gambling, I need some support. They're looking at that. They're kind of groundbreaking things that, in terms of a criminal justice in an organisation, looking at some of these issues, so just focusing on them. Lots of agencies. We'd like to see more logos up there. Again, come and speak to us about this initiative. And that just reflects the training programme really. Depending on what organisation you work with or if you're a particular group, we kind of tailor make some of the content towards the audience. So if it's criminal justice orientated, some of the content will be kind of aligned to their audiences. It reflects that piece of work. So in terms of gambling and criminality, people say, well, what do you mean by gambling and criminality? What's going on? And at the bottom rung of that pyramid there, we often see minor thefts, people stealing from each other, used sometimes domestic abuse type situations, leaving kids at home because they've and that kind of thing, all the way up to more serious kind of issues of fraud and murder. We've seen homicides. I live in Knowsley. I can remember several years ago, a guy came out of a book. He was only a young man, about 19. He ended up killing the guy in the corner shop because he was trying to steal the till. He ended up killing the guy in the shop. So all linked to gambling. And these are the kind of things that we'd look at in our training, particularly with Merseyside Police. 5 minutes, okay. So just a couple of points in terms of the Violence Reduction Partnership and some of the work we've done with them. Back a couple of years ago, we did a seminar that focused on gambling, and Andrew was kind of pivotal in that. But from that, we've been able to kind of cascade heaps of training to lots of different groups, and it was only through that relationship and prevention being a key thing that we've been able to do some of this. We attended Club Health, I think it was a year or so ago. First time gambling had been mentioned within the agenda. And also last year Beacon did a whole families approach conference actually in this building, where the Violence Reduction Partnership were very much a key partner in the delivery of that, looking at what we can do to support families across the patch. Some initiatives with Liverpool City Council, Kind to Your Minds, where they focused on gambling around about the Euro football championships. And we've seen some of that stuff in the last section there, where gambling comes into some of the research that JMU. Sue, can you help me with this?
Yeah, so hi everyone, I'm Inspector Sue Striblin, leading on Project ADA for Merseyside Police. I hope you can hear me. ADA is about reducing drug-related death, supply and usage, but I went to a conference of Ian's with the VRP a few years ago, and I guess this is what we're trying to do here today, is trying to get over, and it's been a very quick whistle-stop tour what Ian's delivered today, but I cannot tell you how impactful that conference was to me, that I came away and have made big changes within the police around how we ask questions to our community. So we've done that through the vulnerable person referral form. Officers go out, they complete that form. It could be for domestic abuse, mental health, vulnerable adult. And when they fill that in, there's now 2 questions there. And again, a big thing that comes out of the training is people are not asked about gambling. They're more likely to tell you they take drugs or they're an alcoholic than having gambling issues. And you can bet your bottom dollar, sorry. There will be people on a daily basis, absolutely, that have gambling issues. Ask the question in your organisation, and if like I say, there's screening tools and there's absolute phenomenal support that Ian and the BCT can offer. So we've now got those questions there. We will probably be asking about 60,000 people every year now in our communities about that. So far we've done it from August last year. We've had about 100 roughly, but because of consent we've got about 30-40 people referred in. Ian talked about that continuum. These are people really before crisis, and that's what we're trying to get. We need to ask people before they're in crisis, before they go into prison. Some other things that we've done really around some of the stuff with custody suites, we're starting to ask questions. We're trying to bring our occupational health unit in. Ian's delivered training across the board. Absolutely would we like the gambling charter within Merseyside Police, because you're right, you know, we could get sacked if we have debts, certainly, or gambling debts, because of potential for corruption. And I've done that Bet You Can Help training. It, like I say, it just really solidified everything that I'd been involved with. Please do it. Like I say, unfortunately, it's a quick input today, but there's so much from children right the way through, and it gets me every time. I'm like that. 4,000 children last night didn't school because their parents are gambling. Breaks my heart. So yeah, so hope that's okay.
You said it better than I possibly could. So just to kind of sum up and recap really, we're a treatment provider. We serve people across the whole of the Northwest as part of that agency, provider agencies in the UK. Not just for gamblers, those impacted by gambling too. If someone gets in touch with us, we'll get back to them in 48 hours to book an assessment. We've got no waiting list. This is the important point: is you can be receiving treatments an individual within 2 weeks. So once we get in touch after 48 hours, that is to book an assessment. Once that assessment's complete and we work out and diagnose what the issues may be, what level of support you need, a treatment plan is produced. The person's communicated with that treatment plan. And then if they're a gambler, we get up to 12 weeks worth of therapy with the therapist. If they're affected other, they get up to 8 weeks. We have really good aftercare and onward support, and people can come back to us. Not going to spend any more time. Lots of different ways of working with those individuals as we're talking therapies and kind of psychoeducation. And I'm not going to show that video, but if you go on our website, you'll see it. But it was just a kind of video that summed up some of the stuff, but I don't want to take any more time. Yeah. Go to the website and find out. Okay, any questions on it? Yeah.
We've got 5 minutes for questions.
Yeah, I just had one around the therapy. Is that 18 plus or work with young people?
Question, yeah. 16.
Okay, great.
So my question is around younger children and the gambling that they are being drawn into with games such as V-Bucks, etc. Do you have any initiatives that are targeting younger children to teach them that behaviour online is actually the beginning of gambling behaviours?
Good, very good question.
Excellent question, very important. I mean, young people is one of our targets. Last year, we worked with 5,000 children, young people in schools, youth groups, agencies that support young people. We deliver training, education workshops to young people to help them explore those issues where gaming is linked and correlated with gambling, and what are the risk factors to that. The wider stuff as well about how do we actually perceive gambling. You know, people don't see it as a risky thing, but there is risk involved. And then if you work with young people themselves, we'll do training specifically to youth workers about what they do in terms of their roles. And
I'm terrified that in 10 years that's going to explode.
already is.
Yeah,
Just
but I
don't
mean,
know.
as these young people grow up and become adults, they need to replicate that behaviour.
Yeah.
You talked about working with some police forces.
Yes.
Are you working with the National Crime Agency?
Yes. I delivered training to them last October. We've got some key contacts in the National Crime Agency, and yeah, we hoping they're going to sign the charter.
Do you look for, I run a community centre, do you look for bases, i.e. different parts of the area of Liverpool that you could have a presence? Because I think it would...
Do you mean to see people?
Yeah, or to
Yeah, I mean, we have got some kind of satellite sites where therapists are based. There's one in particular in Wirral. We have therapists there 2 days a week. So rather than come to Beacon and be seen in Anfield, we might be out in the community. I guess what we would say, we've got them in various places. Blackpool's a key one we just set up.
Yeah.
If there's an appetite and there's a volume of service users, we would look at doing that, you know, being co-hosted by somebody.
Yeah.
So the answer is yes, but we'd have to explore what we need in that particular, you know, location.
I'm based just at Queen's Road in Bootle, just behind Hugh Bird.
Maybe have
and
a
it's something
conversation and
that's
see, even if it's an informal drop-in of some kind.
Yeah, that's what I would think. And it's just for footfall as well. It's obviously community service, but also brings footfall into the building as well. So yeah.
Thank you. We need to move on. Thank you for your questions, and Ian, thank you very much. I'm going to hand over to my colleague Nicole, who will initiate for the remaining part of this session. Thank you.
Very much. Hello everyone, so my name's Nikhil Misra, I'm the health lead at the VRP. I'm a consultant trauma surgeon at Aintree Hospital. Last talk of the morning is going to be from Nicole Russell, who is an emergency department physician at Wiston Hospital. Has been one of the driving forces behind the Knife Savers campaign since its inception in 2018, which has been heavily supported and funded by the VRP, and is one of the UK's most successful and first pioneering knife education and injury awareness campaigns. So,
Alright, so thank you, Nicole. So my name's Nicole. My one hat is an A&E consultant at Wiston Hospital. My other hat is one of the co-directors and education leads of Knife Savers, which we've been running since 2019. To paint the picture of Knife Savers, I want to take you back to the summer of 2018. Sunny like it is, but a lot warmer in the middle of July. There was an incident in one of our Green Park spaces. 27 young people that day. A straightener was called, a fight. A knife was pulled, a single stab wound to somebody's upper thigh, to their leg. That young person ran. They panicked. They ran to the local shops. They ran around that area. And at no point did anybody put any pressure on a bleeding wound that continued to bleed onto these streets. This is his resus room, messy, the aftermath of chaos, but no blood on the floor. He'd already lost his circulating volume before he could even get hands on by any paramedics or any doctors or nurses. Unfortunately, that young man lost his life, and that's not one isolated story, it's a story we've seen over and over again. So as healthcare professionals, something had to change. We had to do something a little bit different. And that meant bringing together doctors, nurses, paramedics, like-minded people to step outside of those hospital walls and out into the community with the aim, very simply, to educate and empower literally everyone. Now, everyone's a big aim, and where did we come from that? You know, we think about Maybe we'll target schools, but what about the young people who don't go to school? What about who do the young people trust? The adults in their community, in their youth centres, in their sports. They need to be trained as well. What about the people out in the pub and the bars at night? What about the nighttime economy? They need those resources. Cabbies going around the street. So it was became very apparent very quickly that this needed to not be limited by age or demographic. By far the most important part of our campaign is education. So getting that message out there of how to control significant major bleeding across our region and beyond. So we do that in a number of ways. We run regular hands-on sessions, both at Aintree Hospital but out in the community as well. Schools, youth organisations, big events at Anfield, using our Jerrys, our mannequins. We've got Jerry and Terry, our real-life mannequins. Gives a real-life immersive experience of exactly what it feels like to put hands onto a patient and to be able to manage that bleeding wound. During COVID, we had to learn about how to do this a little bit more virtually. We were all busy, but also to kind of how else we could get that message out there. And we had to keep it simple. You know, everyone thinks medics, doctors are smart. We're not really, we're just like an acronym. We like that in a panic situation we have something to clasp onto. So we had to have a message that was simple, easy to digest and easy to reach in a panic situation. So ABC, A is for alert, being alert to that situation around you and keeping yourself safe. Are you safe to get involved in that situation as it is? The second part of that is taking your phone out your pocket and ringing 999, alerting the authorities to get help on the way. B, predictably, is for bleeding. So finding exactly where that bleeding point is coming from. They might be soaked with blood all over the place. So really focusing in, taking off a t-shirt, bringing down pants to focus in on that bleeding point. And C, compress to control. One hand over another, putting pressure on that bleeding wound and keeping it there and not letting go until someone's got help on the way. It's as simple as that. But this is a message that we reiterate and reiterate throughout our education. Now, the main limiting factor for us getting that education out there has been our time. You know, doctors, nurses, running full-time NHS jobs, doing this in their spare time. So we needed to take that one extra step. So we're currently in the process of beta testing and launching our e-learning package. This is in 2 steps. One, a desktop set to go to all schools in the region, but secondly also with VR headsets, so an interim between that, sitting in a computer and being in a room with a mannequin, sticking a headset on and really running through that scenario and what it feels like to put hands onto a patient. So this package has been written with the voice of the young people and with the voice of the people who've been delivering it, which are primarily educationalist teachers to start with, hopefully to go on and grow from that point. Looking at the VR headsets, that makes up a package of 4 different videos. First, speaking about families who've been bereaved and sitting down in their living room and talking through that scenario with them. Walking through that that journey from being at that scene to being picked up by the paramedics to the hospital and the police involvement as well, but also in the 3rd and 4th video of what to do when you've got a bleeding wound and how to get hands on. This little video is going to sum that up a little bit more. It's just a snippet out of a bigger video. Really have sound.
But also to do with cleaning, to do with Michael, the entire story really. And I thought that it was a real novel and extraordinary way of so yeah, I was really keen to do that.
engaging and try to really package something that's helpful like where
So you're going to have to narrate your own, and it's like a caption. What do you think Nichol's saying?
To resonate, to what I mean by that is to have a way of delivering a message that's never been done before, and that therefore will last and stick forever. So actually having had a sample of the immersive environment is amazing. It's an amazing way to educate people, to transport them into a different place.
I don't think we're going to get louder than that. So, but we can. What Nicola was saying there was about how that immersive environment allows us to, put a VR headset on a young person, get them engaged, get them excited about it, but also then put them in an operating theatre with a mannequin, look around, see what it looks like, and then be able to, go through those steps of what it looks like to look at somebody and put pressure on. Really good extra step that takes it one step further than just sitting in front of a computer. The other part of our campaign has been about kits and cabinets, and you might have seen them out around the city centre, around the backs of Concert Square, on some of the colleges and organisations up in Formby and in Southport. There's a lot in the educational kits and cabinets, so tools, extra materials that are out there in the community if we were ever to, anyone was to find themselves in that situation of having to manage a bleeding wound. And in terms of does this work? Well, looking at the case reports, a couple of examples of some of the streams of work that we've had ongoing in the last 12 months. So we've had a really good relationship with the LFC Foundation and run several events at Anfield with handpicked young people coming into Anfield and getting a day at Anfield, but also having our education and packages in there. Back in November, we ran a big event with over 100 schools, with over 150 schools in the Liverpool community, who will now have had hands-on training at that session, but also are now the springboard to getting their e-learning into every single school in the region. Merseyrail have been an excellent campaign in supporting us to get cabinets and kits into all 69 stations across the whole region. Every single one of their staff members is now trained in Knife Savers and bleeding control, and that is part of their induction curriculum. Every one of their work phones has our bleeding control app on there, and the next iteration of that is for those packs to be on every single train as well. So really getting that geography covered. Finally, John Moores University, our students, our healthcare students, paramedics and nursing students, this is now embedded into the curriculum to get it first, second and third year, and high level bleeding control, which then has two effects: gives them the skills to be able to manage bleeding wound as they go on their careers, but also for them to be a cohort to be able to go out into community and really spread that message further. So that in their first year they trained over 1,000 students, healthcare professional students. This has been replicated in Manmet, which is now restarting up again, and we hope that more educational universities will take on that model. So they're just a couple of the examples of the really good streams of work that we've got going on. That's just what's in the kits. It's a floating slide, it should have come a little earlier. So first part is a clotty gauze, something that goes into a wound to encourage the body to clot a bit better. The second part is a trauma dressing, a tight bandage to allow another level of pressure. The third and final ditch attempt is a tourniquet, which goes on a wound, on an arm or a leg to switch off a tap. I'm not going to talk too much about that. Come on our training, you need to find out more.
Do you get given those as a pack, do you?
So the packs are available to purchase from so they're our recommended packs. K's Medical is the supplier of the packs and they produce the packs. We very much look at the training side of things and getting that message out there, but they would be the packs that we would endorse. And then finally is just getting that message out there. So speaking to you guys today, we've got our bleeding control app, which is to have that training on hand, in your hands if you ever need it, and as a revision. We're also looking at our media, our social media, making sure that this is household knowledge. This is the same as CPR, as a fast responsive approach. We want the ABCs of legal control to be known at every single household and every single young person in this country. That also involves some discussions at higher level, strategic discussions, making sure we're knocking on the doors of Parliament, making sure that we're talking at our NHS England level colleagues and looking at steering groups of how we drive this forward, but also how we build the research in this area, how we make sure that we're using a health-driven approach to keep driving this forward over and over again. And as we've talked about numerous times through the day, this is all about collaboration. This is about building relationships with the other partners in the city. You know, we're doctors and nurses. We don't work with the young people on the streets. We don't have those relationships, but you guys may do. And we need to make sure we're building those relationships across the organisation. We've been very fortunate to be well supported by the VRP, to have both the means and the networking to be able to drive Knife Savers forward and to get that message out there. But we've also been privileged to build all these relationships with all these other fantastic organisations and more. Is it worth it? Takes a lot of time. Takes time outside of our normal work. But we're talking about 4,000 hospital admissions last year regarding sharp objects and assault. That's probably a little bit of an underestimation as well. We trained over 5,500 people with over 3,000 bleeding control packs out there. We've got 150 healthcare professionals, doctors and nurses engaged in delivering that training. We've been able to get a continuous amount of app users as we're going on, but they're all just numbers. When we set out, we said that one life, one person was enough. We've had at least 5 reported cases up to now of confirmed cases where people who've been on our training and delivered our skills have been able to have a positive influence on a person on the street. February 2020, we'd been into Riverside College in January, just a month before. 2 of their young students ran back into that college after being involved in a stabbing incident. The staff tell us they felt safe, supported and confident to manage that situation. Both of those young people are okay. June 2021, the world was opening up again after COVID. I don't know if you remember, everyone was going a little bit mad, a little bit silly. We all wanted a drink and we wanted to get out there again. 2 incidences in 1 week. In Concert Square in our central hub of nighttime economy. One, certainly a significant life-threatening bleed. The doorman was able to use our training and use our kit to be able to control that bleed. Beyond this, we've had several anecdotal instances as well. A young person who's saw an old guy fall over outside of a chippy. 15-year-old lad who'd been on our training, who was bleeding from a head wound. Everyone stood around and looked at him and he told us that he knew what to do because he'd been with us. And in terms of the feedback, we tend to have a very willing audience come to us. People who want to know what to do and want to change, but they don't feel too comfortable with it. 27% don't preparedness before our sessions. That raises up to 98%, both to manage bleeding and to use PAP. That's a really positive number. So what's next? We talked about our e-learning package. We want to focus on getting that education out to every person that we can get. Education is our core value because knowledge is power. So we want to make sure that that education spreads us to as many organisations as we can, in whatever form we can get that out.
Presentation, real showcase of what we do. So probably about 2 or 3 minutes of questions to Nicole, and then we'll do general questions for 10 minutes or so.
Just in relation to your app,
Yeah.
does that actually show you where the bleeding kits are in the city?
Great question. At the minute, no. It's something we've been working on since the start of inception. So what is happening at the minute is all the cabinet data is getting fed into what we call the Good Samaritan app. That's an app that's used from the Merseyside Police and NWAS and can be accessed by other people as well. So they will be located and they have that then the access to that information is there. The rest is a little more difficult because people move things around, so we want to make sure that any data we put out there is accurate. The last thing we want is to direct someone to a kit that's not there.
Would you put them across? Would you put them with the DFib?
Yeah.
You know, like in the same sort of location, so people
Absolutely.
go.
That's absolutely the perfect place for them to go.
Yeah.
I suppose they're in town centres.
Sorry, just
Well, co-location was my first point, I think, because there's already maps for those as well, where the defibrillators are. But is there any grant funding that we can access to get kits en masse to defibrillators?
Yes, is the short answer. It doesn't come from us because we don't have the funds. However, lots of our partners have done that. So LFC Foundation got a grant for all the schools in Liverpool to get the kits out in every school. In Southport area, there's significant grants and fundraising for kits and cabinets across the region. So there are definitely pots of money out there, and it's definitely been utilised for that purpose. I think the most important is making sure we back up that up with training, because the kits is one thing, but a piece of kit is useless without that education around it.
so 2 more questions. Gentleman here, the lady over there.
Very quick one. You know, when you like the environment time, and we have to do a first aid course every 3 years, couldn't that be introduced into it along with that training?
Yeah, absolutely.
Make it like compulsory, the same as the first aid course.
Yeah, and there is roles for it being compulsory in different streams. So yeah, we're absolutely happy to have a conversation about that.
Yeah, it's in relation to the kits. Are there other kits out there? And I asked the question because I work in St Helens, and I know that one of our local charity organisations has informed us that they've got kits that are now publicly accessible, although we weren't involved in it. I worked for the local authority. So I'm just wondering, is there just one kit or is there several?
Yeah.
Question.
Absolutely, it's an open market, isn't it? So it's not, you know, we endorse that kit based on our healthcare knowledge and what we this mirrors what we use in the hospital setting.
Yeah.
It's a growing field where there's a lot of bleeding control equipment that's being out there. But what I'd encourage you to do is look at the evidence based around it. So is what they're kitting actually fit for purpose?
If I'd have known that they were planning on doing that, I might have had a conversation, but I didn't know, and now they're there. So it's like, so it links into the question therefore on location. So if there are several, if charities are trying to raise money to buy kits and they're not buying it from you, but they're buying it from somewhere else, it's the issue is where they're everywhere, but where are they? Yeah.
So I'm going to connect those dots. So it's the Daniel Fox Foundation who reached out to us because they were worried about the quality of the kits. There's a minimum standard of the stuff in the kits. Now we researched this extensively and have used the medical and military grade of kit that has been used on air ambulances and the UK military have used. So that's our minimum standard. We can't advise anything else, would never advise anything else at all. So in fact, just specifically the St Helens group, the Daniel Fox Foundation, the chap reached out to us and said, I don't know what I've done. This is here, I've looked through it, and the stuff that's in there is the stuff that's in our kits. It doesn't matter, you know, what the kits are, as long as they meet that minimum standard. I'm going to roll this one back. Actually, what the Power of the Knife Savers campaign has been shown to us, we thought it would be the kits and the cabinets. It's not, it's knowledge.
Yeah, I would say that on the training.
Our biggest strength that has evolved that we've found out is in schools. Because we're not just all about bleeding control and the very basic, simple biology of bleeding, the stuff that we do every day, translated and made simple. We are relatively simple people. We want to strip that down to basics so anyone can digest and understand that. We talk about the dangers of a single knife wound, but we don't wear uniforms and wag our fingers. We're not positioned in a position of authority. And we fill a particular space that we find we're being listened to. As doctors and nurses who, you know, in the last 48 hours, Nicole and I dealt with bleeding and being stabbed. And actually, to then translate that to a room full of 100 young people, we're listened to. Being in a room of 100 young people with pin drop silence, it's rare. And then they come and talk to us about our lived experience, and we realise we're in their heads now. So it's not just that fact that we've got bleeding control in their heads and how they have to act in a time-critical fashion, but also that danger of a single knife wound. And rolling that back to Nicole's excellent presentation, the very first few slides, this is where we started, a single knife wound. We see this time and time again, causing mortality. strongly believe that that knife wound was brought out and used as an act of impulsive violence. But actually to get that idea into the young people's heads, and actually everybody's heads, that acts of impulsive violence lead to death, essentially.
And just one other question. Is this part of, if you're going to be a doorman and you're looking for your SIA qualification, does this form part of that qualification? If it doesn't currently, how do we influence making it there? Obviously.
So we've been working on the Liverpool City Centre with a collective there, parked it to one side because the education streams took over.
Yeah.
But yeah, definitely look at that again. I think we've probably got about 8 minutes of general questions.
Cost of kits.
Sorry?
50, just over 50 quid. Yeah, for the kit.
Yeah, we just purchased some of the VRP to send out to our community partners and to the local youth eventing teams, so they will be given out in the next couple of weeks. It just arrived yesterday actually.
Yeah, that's brilliant, and this is the example of that. The VRP have massively helped us in every school in Merseyside has been involved with help the LFC Foundation. Every school in Sefton, if you can go around Sefton, big red cabinets on the outside now. They're our cabinets that we designed to make them public accessible. Trains have got them, train stations would have them. So those kits are really important. But as I said, what's really, really important is the knowledge. That's the point that right, I'm going to open up to general questions now, if that's okay, for the last 8 minutes. So, yeah, thank you very much, Nicole. Much appreciated. Great presentation.
Mine is a sort of a general thing, but it comes back to the Lifesavers. I've done the Lifesaver training when it was in lockdown, and then done the real life version with the mannequins. And using them is an absolute lifesaver. It's fantastic. All of our detached teams in Liverpool City Council and our mobile youth bus have got the knife packs on our things, and they work. You've not had to use them, touch wood, we'll never have to use them, but they're there, and it's the quality of the kit and actually using it with the training and the kit. Because having that kit there without the mannequins, it's the connection between the two actually is key as well, and it's the education.
It's really good feedback.
I probably would have had the answer to this question had I seen your video. I think it's a brilliant initiative and it's great to see how it's been rolled out. So I'm working with the other VRPs across the North West as well, and I know certainly Lancashire we're looking at similar with the bleed kits now and rolling it out. I think the concern maybe is, or not a concern, but with the training, we don't want to get to a point where maybe young people are running around looking for a bleed kit that might not be anywhere near them, and actually they need to apply the pressure there and then so they don't bleed out. So it's just how that training is delivered to make sure, you know, like you say, Concert Square, it's right in front of you, perfect place to use it, and it's a fantastic piece of kit to have in front of you, but just really getting the young people to understand if it's not readily available, this is what you do in another way. And I work for North West Ambulance Service, so obviously we don't, if somebody rings the ambulance, we won't direct them to a bleed kit, but we'll also, you know, obviously educate them on how to apply the pressure, etc.
Absolutely, and that's a key vital point where, and I absolutely, completely agree with you, and all of our training is very much focused on what you do without a kit. And also, you know, ultimately, we've talked about kits quite a bit here, but again, as you say, it becomes a distraction, and we need to make sure we're focusing on that training of what you do when you just have your hands. And the first 45 minutes or so of our training is all about that. It's the ABCs, but broken down of why that works. The kits is an extra bit, it's a talking point, it's a bit of fun, it gets them involved, but really breaking it down to that ABC is what is important. And we would never move away from that.
It'd be good to speak to you maybe afterwards, because obviously we're trying to widen it through the North West, and obviously the ambulance service are trying to assist in that because it's a great initiative. So it'd be good to try and get some videos up and running for the rest of the North West. So,
I think it's spot on. I think the core message that we give is don't go running around for a kit. Press hard will save a life. If the kit is there, there's some bleeding that won't stop from pressing hard. That's where the kits come in, basically. So yeah, really good question. 5 minutes left. Can we open up the questions to our other speakers as well? So to Jane and Abby, any questions for these guys at all? Any points or questions? I would say to Jane and Abby, actually, having worked with you for however long now, basically, I think your work is phenomenal. It's changed the way I approach patients in healthcare. We've got some colleagues from the NHS here as well, some frontline clinicians and some operational managers. I'm very much going to connect with you afterwards. And as you know, I really want to embed what you do into the National Health Service, which is another massive grand claim. We've got to start somewhere, haven't we? You know, everyone who sees a patient, an injured person, needs to have this science that you're giving. And it will change our practice. I have no doubt the way that we change people. We've got our navigators here as well. What do you guys think? I mean, have you seen the trauma practice?
Well, we are trauma informed. We are trauma informed trained, but 100%. You know, I thought that was fantastic about the that whole demonstration of, and also what it made me think about is it made me think about not so much young people, take it back further into children. When children, when that connection is being constantly removed all of the time, you know, why do our young people translate into these horrendous, horrible situations? Well, the reason why is because way back, when they were very small children, that oxytocin is being removed from their lives through non-engagement, through a number of different factors.
I think that links into your previous presentation on the docs with the Jenga, which I'll never forget.
I think that's the key, is when we can actually embed that understanding in the Jenga blocks and get people to see it as gaps, and gaps we can fill if actually we reconnect with people, we change outcomes completely, and that's the difference.
I think it's really important for you guys to know the potential effect of your work in hospitals. And I suppose the challenge that we have going forward is how do we upscale what you do to the regional NHS? I'm now not just talking about the Royal, the Major Trauma Centre Aintree all day, but also Wiston. Callum's here from the Major Trauma Networks. That's 10 hospitals, 9 hospitals across the Cheshire and Mersey Major Trauma Network. So all of those hospitals are designated major trauma units. So anyone that gets injured as an act of violence that doesn't trigger coming to a major trauma centre will go to these hospitals. So how do clinicians there get what's in your head?
And I think we've sort of started that journey. We started it with the drug and alcohol teams within the Royal. We've now supported some staff from, and we're working with the mental health team in Sefton. And I think it's how we permeate that throughout the systems, so that it's not just something that's written on the wall. It's something that's absolutely ingrained in the way that we're thinking.
So you've got clinical champions. I mean, so that's where our model is that we're going to push what you're saying forward into our healthcare spaces. Sorry, sir.
I was just going to say, within Combat and Drug Partnerships and Project ADA, that we're also looking around reducing the stigma. And I know I've mentioned this to Abby and around this. So there'll hopefully be a Northwest event, NHS, everybody's involved. Professor Harry Sumnall from John Moores University is leading on that work at the moment. But I think that's where this is fantastic that we're doing that within the police and partners. But it is around reducing the stigma, because once we understand that trauma, helping to really be more trauma informed, it does reduce the stigma across mental health, drugs, alcohol, sex working, etc. Gambling, and I think
it all interlinks everything.
Starting to move the culture, certainly within the police, and I'm trying to do that within ADA and the training that we've done around just around language. Don't be using the word junkie, smackhead. A term that people have been using for a long time, and a lot of people who use drugs will call themselves. So it's just step by step, but I do think we're moving forward, and hopefully within this Northwest event that might be getting held, I hope.
Very good idea. I'll link with you afterwards.
Yeah, I mean, for me, it obviously continues professional development in any profession. So it should be built into that as part of the continuous professional development pathway. And more importantly, it should be part of the training that you receive when you're training to become a doctor.
Oh, 100%.
Or a police officer, or anybody that works with members of the public in any direct facing way.
It seems intuitive and logical. If anyone is in the public sector, do you have, in healthcare, we have to do mandatory training. Do you have to do mandatory training?
Yes.
We've got about 73 modules we have to do.
Yeah, I know.
So it's fitting this, which I think is essential, into the core part of mandatory training as a real challenge. So, someone have their hands up? Yeah.
Yeah, I think it's probably just to tail on to what you're saying, again, because I work for the North West Ambulance Service, and exactly what you're teaching, you know, we're in and out of people's houses just as much as the police, fire service. You know, that escalation of behaviour is something that we see time and time again, but may not be at the forefront of our minds at that moment. And we've really got to change the culture within the organisation to get to that, so we see the escalation, especially in our young people, and that we're feeding that into our partners. So I suppose it's you know, obviously a massive organisation being the North West, and it's whether you are rolling out those train the trainer type courses, so actually we can start to roll it out.
We're also looking at parent training, which will be a stepping stone towards the trainer model. So the intention with parent training is that we actually deliver people who can then deliver to parents in that trauma-informed way. So that's our next intention. That starts in April.
I'll be emailing you, I'm sure. So yeah.
I'm drawing the sign of a really good session is people don't realise it's lunchtime and it's still rumbling stomach. I say thank you very much to our speakers, and thank you very much for coming to that. It's lunchtime. Just is it upstairs?
Just upstairs, yeah.
Thank you guys.